Good morning, everyone. I'm Tom Miller, Director of Analytics and Research Services at the American Society of Anesthesiologists. I'm very glad to be here and I appreciate the opportunity to moderate this session. We're excited to hear from Lisa Stewart this morning on current initiatives at the Patient-Centered Outcomes Research Institute, or PCORI, initiatives that improve diversity and inclusion in patient engagement research. Lisa Stewart is a Senior Engagement Officer at PCORI. She acts as a liaison between the engagement and science programs, helping to manage the organization's research portfolio and supports the engagement of patients and other stakeholders throughout the course of research studies. Prior to joining PCORI, she led patient and stakeholder teams as a co-investigator on patient-centered research projects. She began in health systems as a patient family navigator in pediatric care, providing peer support to families of children with complex medical conditions, and serving as a consumer representative on system-level quality improvement initiatives. Lisa co-led the Children's National Health System's Patient and Family Advisory Council and the Community Advisory Board for its NIH Clinical and Translational Science Award. She was formerly a member of the DC-Baltimore Research Center for Child Health Disparities and a qualitative researcher for the District of Columbia's Community Health Needs Assessment. We're also joined by Dr. Debra Joy Perez. Dr. Perez is Senior Philanthropic Advisor and Independent Executive Consultant to national foundations and federal grant-making entities. Prior to her consultation practice, Dr. Perez was Senior Vice President for Organizational Culture, Inclusion, and Equity at Simmons University. We have asked Dr. Perez to be a reactor to Ms. Stewart's presentation this morning, and she will be part of the Q&A session. Welcome, Lisa.
Thank you, Tom. Good morning, everyone. I'm happy to be here with you. And I just want to echo some of the early remarks that yesterday was simply phenomenal. I do have to apologize that I'm by the window right now. There may be some ambient noise that comes in, but I think it's something that we all can get used to and embrace in this Zoom environment. In this update today, I'm going to touch briefly on work that we've been doing around COVID-19 and engagement, share with you some of the early findings out of PCORI's research on engagement, discuss some activities that we are prioritizing now, and end with an invitation for all of you to provide input on an important new development that arose out of PCORI's reauthorization. This has been certainly an extraordinary year for PCORI during these extraordinary times. Just 12 months ago, PCORI's future was uncertain. But by late December, PCORI was experiencing tremendous excitement that we have been reauthorized by Congress for another 10 years. That achievement was made possible in part by the support of many individuals and organizations for which PCORI is grateful. Then shortly after reauthorization, excitement within the organization was elevated even more by the news that Dr. Nikayla Cook would be assuming the role of PCORI's next executive director. Dr. Cook, a cardiologist and health science researcher with an extended background in health disparities, assumed that role in April. If you've not had an opportunity to hear her speak and to get a great view of what PCORI is doing and thinking about, I invite you to view archived presentations from our annual meeting that took place just 2 weeks ago. Of particular note, and in relation to diversity and inclusion, I encourage you to look at the session Standing Up to Racism, Discrimination, and Bias, a dialogue on health and healthcare equity, as well as the keynote presentation that preceded that panel, led by Lisa Cooper, entitled Racism and Discrimination in Healthcare, Raising Our Collective Voices. When we think about doing the collective work that is needed to eliminate disparities, we see engagement at the core of building and implementing solutions. Next slide, please. In response to COVID-19, PCORI quickly responded with several initiatives, the largest being the Healthcare Worker Exposure Registry, also called the HERO Registry. The objective here is to build a community of healthcare workers that are organized to understand and mitigate the effects of the pandemic on healthcare workers. Currently, there are over 16,000 individuals registered from all 50 states. This includes doctors, nurses, respiratory therapists, transporters, food service handlers, environmental service workers. In other words, the entire range of workers found within healthcare settings. Studies that may come out of the registry may look at the effects of COVID-19 on minority healthcare workers and the impacts on children of healthcare workers. PCORI, throughout the establishment of the registry and these projects, relied on important input provided by a multi-stakeholder advisory group. In addition to the HERO registry, PCORI issued a targeted funding announcement that prioritized the study of adaptations to healthcare delivery that resulted from the pandemic, the impacts on underserved populations, and healthcare workforce well-being. PCORI is also providing support to already funded projects that have needed to make adaptations to fit the current environment, or have sought to make enhancements that would result in new learnings that could be born out of this unforeseen and unprecedented context. PCORI is seeking to learn from some of these projects how engagement is changing due to the pandemic. What flexible methods are studies employing? What quick turnaround ways are studies using to gain input? To what extent has the pandemic affected patients' ability to engage? And how is patient and clinician expertise being utilized to come up with strategies that can keep trials going when many have stalled? Next slide. From the very beginning, PCORI has held as a core belief that engagement makes research better. Building from community-based participatory research, participatory action research, and other approaches that sought to equalize power by being inclusive of communities in the design and conduct of research. This concept was seen as disruptive, one would say, in the early years of PCORI. It's been really rewarding to see how in just a relatively short time, this has taken wider acceptance. When PCORI posited that engagement makes research better, there was no evidence that it actually did, that there was high demand for proof of its value. What was the ROI we often heard? PCORI is in a unique position to answer some of these questions. PCORI has conducted and commissioned observational studies about engagement. We've conducted more than 120 in-depth interviews with researchers and research partners. We've reviewed more than 125 peer-reviewed articles submitted by our awardees. We've conducted hundreds of surveys. And we have the accumulation of practice-based knowledge acquired by engagement officers who provide engagement support and engagement on projects. The results of these multiple studies of engagement confirm that engagement is indeed making a positive difference. Next. A key learning that emerged from our most in-depth research on engagement of PCORI-funded studies relates to the impact that engagement is making. We've learned that engagement is improving the acceptability of studies, meaning improving studies in ways that make them more aligned with the values and preferences of patient participants and more easy for them to participate in a study. An example of this may be something that we see quite more common now in the pandemic setting of using e-consent forms. We learned that engagement is improving the feasibility, meaning that the contributions by patients and clinicians and administrators are altering studies in ways that are making them more pragmatic, more doable in real-world settings. Engagement is also improving the study rigor and comprehensiveness, as well as relevance. And we're also learning that the iterative nature of engagement means that engagement over time within a study tends to improve because real-time changes are making throughout the process. Next. We also gained a greater awareness. We always thought this was true, but we certainly gained a greater awareness that engagement can take many forms, that engagement does not look the same in all and in different contexts. It's constructed differently based on the needs, resources, and structure of studies. And even within a study, there's fluctuation about how engagement operates and how it looks. On this slide, you'll see a continuum based on decision-making authority of research partners, from low intensity methods of engagement, which we consider to be one-time events, like focus groups and town halls and crowdsourcing, to consultation, which is what we consider to be the relationship of stakeholder advisory councils, committees to studies, to collaboration, and those would be scenarios in which there's a patient co-I or multidisciplinary executive team, to shared leadership. That's when the patient partner is a co-PI or manages certain leadership responsibilities. The directional arrow at the top is leading to an endpoint of patient-led, patient-driven research. And again, within studies, we're seeing these various forms mixed at different points in time. One particular form may have greater prominence. Next. What we also know from our evaluations of engagement on studies is that research partners are making contributions and impact in every aspect of the study. They're not only working with research teams at the onset and conceptualizing the research questions and interventions and outcome measures, as well as methods, but they're also contributing to recruitment strategies and data collection and interpreting the data as well as dissemination. Next. PCORI believes deeply that it's not enough to invite patients and other stakeholders to the table. It is the responsibility of the entity who is doing the inviting to provide adequate preparation for research partners to participate fully. Being inclusive requires that opportunities are provided that allow for knowledge and skill building. A priority of ours is to develop resources that support stakeholder inclusion. This summer, we released the training package, Research Fundamentals, and in the coming months, we will be releasing a second learning package called Building Effective Multi-Stakeholder Teams. This will provide instruction on material important to working on multidisciplinary teams that include issues like managing decision-making and handling disagreement, understanding bias, and creating environments for respectful interactions. Next. Here's a look into the Research Fundamentals learning package. At the bottom, you'll see the topic areas covered around the key stages of CER, comparative effectiveness research. And we were very intentional in the casting of the characters and in the images used to represent diverse groups. Gender and racial ethnic diversity was intentionally used in representation in positions of authority. We think it's very important for potential partners to see themselves in these roles, as well as to help with developing mindsets around who should and should not be in positions of authority. Next. In the coming year, we will continue with, we will maintain our priority of conducting more research on engagement, as well as developing and promoting more resources that support engagement. We also, within that realm, we're looking very closely at practices that support inclusion and that lead us to health equity. And this slide is just looking at one of the topics that we, among many, are thinking about quite a bit right now, which is trust and trustworthiness. And how do we develop that? What are the practices and behaviors that signal trustworthiness? The complexities of this issue within research is multifactorial, as we know. For the people who we want to attract to be research partners, it's important to understand how their perceptions about research is formed and how that perceptions that arise from experiences within healthcare or related to certain institutions inform their interests in partnering with research. In this current environment, we know that in addition to all the complexities that have always existed around trust and trust building and trustworthiness, that there's even more weightier factors in play right now with skepticism about science and skepticism and mistrust pertaining to core institutions. What we know is trust must be cultivated, and engagement and trust are mutually reinforcing. Engaging with research partners, a method and intervention, if you will, in addressing mistrust. Staying with this issue of trust for a moment, and this slide taken from an article out of a IMF publication, we see how trust has shifted in recent years, moving from what's depicted at the top, from people trusting the messages of authority figures, moving down to a horizontal level of influence, that meaning that people are being highly influenced. That's a state in which people are being highly influenced by people who, quote unquote, look like them, people who share demographics as they may do. And going down to the bottom, for what this article is positing is that trust is very localized now. How we develop, how do we, the influencers that help create trust, we're relying right now a lot on very local factors and very local relationships from our community, workplace, and family. Next. And we see that here. These images are of two different community leaders, and leaders being understood and defined by the communities themselves as opposed to appointments or otherwise. In the first slide, we have Freddie White Johnson, and Freddie is an extraordinary force within the Mississippi Delta. And in this picture, she is working with a group of community health workers, male community health workers, and they're delivering masks to people in the neighborhood. And I think what's important here is to recognize that Freddie works for the University of Southern Mississippi in a research arm, a research area of that university, but it's her reputation and her backing, which changes, which allows for the university to go into the communities that she's deeply connected with. Likewise, in the second image, that's actually not who does work not too far from me in Silver Spring, Maryland. And he became engaged with being a conduit for people get to access to health care, as well as information about health research after his father received a diagnosis. And from there, he decided to take his platform of being a community counselor and community influencer to help bring forth information and opportunities that his community had limited access to. So those are just two examples of people who are doing the work. It's something that we say often, that you need to work with communities and community brokers. And I think it's also a little bit different when you see it in action, because one of the questions generally becomes, how do you reach people? How do you reach a Freddie? How do you reach a Barbara? And you have to have inroads into communities and not shy away from that. Next, please. We also hear, you know, as almost a mantra in the most positive way, meet people where they are. And I like to think with you for a moment, like the many ways that we can consider that, meet people where they are. In this, on this slide, in the top image, we have two researchers from George Washington University who are working with trying to increase enrollment of African Americans in a vaccine trial. And they are standing in front of their mobile van unit, right? So they are actually going out into the community, physically going out to the community, working with community partners and asking people to enroll, and they met their enrollment mark. Right beneath that image is a picture of a nurse receiving a vaccine. And this still, again, playing with the concept, meet people where they are. For a lot of people, and we're seeing this more and more, of doctors and nurses and healthcare workers who are getting the vaccine, to take a stand for the patients that they serve, and to signal to their patients that I'm willing to take a risk because I think it's important, and I think it's important for you. So therefore, people making conceptual links, because providers are such influencers, that they themselves may indeed try out the trial. And again, staying with this theme, meeting people where they are, this is with the last, in the previous example, making some relational ties. Here in this image from the COMPARE study, this is taken from a recruitment video. And it's a video that features a father and son talking about getting testing for prostate cancer. And in this, the setting is a home setting, it's intergenerational, and it features people who the trial targets. So people can see themselves in relation to these images. Next. And closing out this, this topic of trust and working with communities, I think it's very important that we do the work of debunking myths and interrogating our own assumptions. There's often a sense that people from underserved communities do not participate in clinical trials at the same rate as whites do. But in fact, studies have shown that if asked, people from underserved communities will participate in trials. African Americans are known to, these are a few articles that attest to African American participation in particular. But what we know is that there's also another factor, a variable that is a part of this equation, and that is the bias that comes from clinicians or people who are enrolling in studies where they either are not providing information, assume that a particular patient is not eligible because of comorbidities or assumptions of comorbidities, and a level of discomfort about approaching people who are different than themselves. So to engage with communities, we must check our own biases and recognize that structural racism builds from individual racist beliefs. Next. In closing, I want to loop back to PCORI and where we are. We are presently in a strategic planning process. We are taking input that will help us with structuring our national priorities, from which our research agenda will be, our new research agenda will be developed. And all that is taking place over the next year or so, with different opportunities for input. And next. And finally, I want to just close with an invitation. What's from one of the manifestations that came out of the reauthorization legislation was an expansion of the collection of outcomes data to include cost data, such as medical out-of-pocket costs and non-medical costs and expenses to patients and families. To operationalize that, we are first embarking on drafting a set of principles that consider the range of outcomes data. And we like to collect as much input from patient advocacy organizations and other stakeholders, including industry and payers and purchasers, to understand if these principles really get us to a place that will help us guide us in operationalizing this for researchers. So I invite you to attend one of the two seminars that are occurring next week, one on Monday and one on Tuesday, and to submit public comment by November 13th. So that was a little bit of a commercial as I close out and transition to reaction by Dr. Debra Joy Perez. I just want to say thank you to particularly call out our advisory panel on patient engagement. As you know, PCORI is an organization that seeks and maintains connections with different stakeholder communities, and our PEEP is a vital component of that. And one of the current projects that the PEEP has undertaken is developing a set of development and inclusion principles that they are going to recommend for PCORI to consider as we think about how we will operationalize DE&I within research. So with that, I turn it over to Dr. Perez.
Thank you so much, Lisa. I'm delighted to be a part of this conference and this conversation, and also excited to be offering my reflections and remarks on your fabulous presentation. Part of what I want to do today is just share some opening remarks to set the broader context for this conversation in terms of what we're seeing nationally regarding inequities and xenophobia and other limitations to patient engagement. I also will share my reaction specifically to the points that Lisa Stewart made in her presentation on the update. I want to start by saying I've spent 20 years working in philanthropy, professional philanthropy, as a vice president and chief of research and evaluation. So I know research and evaluation fields very well. A lot of my work in research and evaluation in philanthropy has been focused in equity and equity issues, and in fact, engagement. In the case of some foundations, it was focusing on the engagement of researchers to ensure that there were more researchers of color engaged in our work. And in others, it had to do with evaluation and participation of nonprofits in our work. My background's in public health and in racial ethnic disparities. And at the time when I was completing my PhD in health policy, my dissertation was on mental health outcomes among Latinos in the US and the impact of discrimination and xenophobia on that health. So it's no surprise that even as we are experiencing COVID, that one of the factors impacting the experience of COVID has to do with discrimination and xenophobia and its devastating impact, particularly on African Americans. In fact, it was over 20 years ago that the impact of racism on health was described by Arlene Geronimus, a professor in public health at the University of Michigan, on this as this concept of weathering, like the idea, notion that racism and xenophobia and just exclusion had this weathering effect on people's health. And that's why, again, patient engagement is so important. Today, we're hearing even more explicit languages on the impacts of racism and white supremacy on vulnerable populations. And how might these feelings of fear and racial anxiety impact patient engagement and patient outcomes? This is something very important to, I think, all of the patient advocacy groups in this conversation, as well as to organizations like PCORI that I think have been taking the lead on a better understanding of how these dynamics can play out and how to overcome them. In public health, we've been talking about social determinants of health for decades, and what we're seeing play out now during this pandemic is textbook socioeconomic disparities, racial and ethnic disparities. We must begin to ask ourselves, what would it take to create a more inclusive and equitable research environment, not only in the time of COVID, but in a time where explicit racist rhetoric and calls to stand by are prominent? What can patient advocacy groups do to not only overcome, but to counteract the narrative that in order to engage the very patients their advocacy intends to support? So part of the answer, and I think Lisa alluded to this, and I'm really excited about the work that they've done, is engaging patients and understanding kind of their value. What is their value that they bring? One of the things I most admire about PCORI is it recognizes the monetary value of patients' time. So it recognizing and it puts in the proposals and allows folks to fund patient engagement at a level so that their time is honored, right? So I can also say that I think that what we're learning now, specific to this particular time in inequities and disparities, is that COVID has not only had an impact on the lives of, say, kidney transplant recipients, cancer patients and survivors, folks with heart disease, or any number of the existing conditions that the bodies in this call represent, but COVID is having an impact on their lived experience as human beings. Not just the physical, but what is the emotional and mental health of those individuals, and how might that impact patient engagement, right? So specific to Lisa's points, I want to highlight two that I think are very critical. And one is, first of all, I'm a fan of an organization that is so self-reflective, right? Like Lisa spoke to this, like we are in a very different place today than we were in 2014, right? And on issues of engagement, what we know now, thanks to PCORI, we didn't know then. And so they went from a belief to actually demonstrating evidence. And that's something that I think that she mentioned that it's worth highlighting. I resonate with yesterday's speaker, Dr. Beyer, on, despite all of the obstacles and challenges of engaging patients from diverse backgrounds, it can be done. And I think for me, that's the motivation of this work. It's not just talking about how things are awful and inequitable and racist, et cetera, but to Eduardo's point, how do we get from there to being actively engaged in countering that? How to be an active anti-racist, right? I also very much appreciate, and it was mentioned in the comments, the elegance of the conversation on trustworthiness, right? And this is something I think people on this call should take very seriously. There was a time where people trusted scientists, right? There was a time when people's most trusted profession was nursing and nurse profession, right? And now what we're finding is people are so isolated and so fearful and so impacted by the negative rhetoric that they only trust someone who is literally next to them, right? And I think that's something worth discussing. And there is something to be gained, I think, from the move from a hierarchical structure of trust to something more lateral, but there is also something lost, right? And the part that's lost is that we're not influenced by people in the field who actually have spent their life's work developing expertise in an area. So in closing, I would say that these strategies that Lisa laid out and the work that PCORI is doing is absolutely on point, meeting people where they are, and the benefits of research, particularly for BIPOC, Black, Indigenous, people of color, are beyond just having the right representation so you can do a suitable regression analysis. It's about getting it right so the impact is enhanced. And I always, and Lisa knows this about me, whenever I talk about equity, I say that there's probably lots of arguments for advancing equity. Having a social imperative is one, doing the right thing is another. But certainly for me, the key driver for equity is excellence. Nothing we do can be defined as excellence if it does not include an equitable and equity-centered approach, right? So I think, again, developing these principles is really critical and exciting. I think, the principles that support and guide organizations to identify their own translation and operationalization of those principles is really helpful. How patient advocacy organizations and principles allow them to do the research the way they do them, but ask the tough questions about, who's engaged and who isn't, who's included, who's not, who's accountable for our commitment to equity. And so these principles, I think, will result in stronger research and better outcomes. And so I really also appreciate that shift finally in that mindset from, from feeling and believing in equity to actually taking action. How does equity become operationalized, right? I always say that allyship is great, but ally should be used, as a verb. It's an action verb. You're not an ally when you're standing by. You're an ally when you stand for and stand up. And so with that, I'll turn it back over to have another discussion. I really appreciate the opportunity, Tom. So
Thank you. Thank you. Thank you so much. And just to mention that we had a number of people commenting on the 5 dimensions of trust. They really like that framework. And some people asked, what about the trust of the patient representation? So we unfortunately don't have time for questions, but thank you for that excellent session. We appreciate it.